Sorry to disappoint everybody because Gary was going to present, but you're stuck with me today. So 60-year-old guy, he comes to you to see you in clinic, and he has severe back pain for 2 weeks with difficulty walking. And on exam, he has a temperature of 37.9, poor dentition, and he has weakness with hip flexion. So he's able to move his other muscles in his legs, but he has a really hard time flexing his hip, and just walking in general is difficult for him. So you saw the title. We're talking about discitis and osteomyelitis. When is a spinal problem an emergency? Thinking beyond just infection, when do you think to send a patient to the emergency room? There's not that many spinal emergencies. Lindsay?
If someone comes in and they have true bowel or bladder incontinence, that would be probably something.
Okay, and you're worried about cauda equina. So yes, cauda equina is an emergency. I probably operate on a patient with cauda equina like 1 time a year. So we know about cauda equina. Everybody knows about it. It is not that common, but it is an emergency. And I think it's a very important thing that everybody in the room, whether you're in surgery or whether you're in chiropractic or physical therapy or pain management or anything else, that you recognize the emergencies in spine. And cauda equina is kind of the classic spinal emergency. Yeah?
I'd say worsening neurological deficits that just aren't making sense.
Uh-huh.
Like we had that one patient with the sort of the upper extremity thing that happened.
Yeah.
So
yep.
Visit to visit, it's just getting worse. It's not progressing the way it is.
Yeah, so if you're thinking in categories, neurologic deficit that's worsening becomes something is not right. You should not be unable to move your leg or something. And then the specific causes would be another bucket to be thinking. But yes, absolutely, worsening neurological deficit. Alex?
I think in the setting of trauma, if someone's had an acute injury in an accident, and they're experiencing any symptoms, even just back pain. We had a patient that was a 20-year-old college kid last week that jumped off a roof onto a trampoline and couldn't move because he had intense back pain. Ended up just being a compression fracture, which there's really not a lot of intervention for, but that's an appropriate one to get looked at.
Yeah, absolutely. Trauma is probably the most common neurological spine or spine emergency. We deal with trauma all the time, and the reason they're in the emergency room is because they've had a recent accident. One particular case that I think I've shared before was a young man that took a dive into the snow, and he had a lot of neck pain. He had some tingling and maybe a little bit of weakness in his upper extremities, and he went to his neighbor who was a chiropractor. And so this neighbor was dealing with what proved to be a burst fracture with spinal cord compression, and he was a chiropractor who wisely ordered imaging and escalated the care. So spinal fracture, you'll have a history for it. We had a patient last week on call, or the last time I was on call, no, it was the time before, that had a fall. He passed out in the bathroom and he fell and hit the top of his head, and he had a unilateral jump facet and kind of just didn't do anything about it for a few days before he was having worsening radicular pain and an unstable situation that needed attention. So trauma is probably the most common, and so asking questions about these things is important. Other neurological emergencies, or spine emergencies, sorry. Ken?
Intractable pain, patient that just cannot get any sort of relief.
Yeah. So that's again in that category of symptoms, and a lot of emergent problems can cause intractable pain. That's relevant to this conversation, and some of the cases that we'll discuss, one of the most common presenting symptom was intractable pain. And they didn't have deficits, they didn't necessarily have fevers, but they were in uncontrolled pain. So that's definitely a thing to not hesitate to say, there's a few things that could be going on here. In my outpatient setting, I don't have all the resources to figure this out. So let's get you sent over.
I'd say like uncontrolled headaches, blurry vision, those neurological symptoms that progressively get worse, big tumors, things like that.
Yeah, so spinal tumor is and can become an emergency. Ironically, most of the spinal tumors are not emergencies because they're slowly progressing, and usually they reach some sort of tipping point where now they become emergent, but they're sort of not nearly as emergent as, say, a cauda equina or a acute osteomyelitis would be with epidural abscess. But yes, tumors would be another category of pathologies that need immediate attention. Brandy?
I've sent a couple of patients to the ER with like rapidly onsetting myelomalacia or myelopathy.
Uh-huh. Yep.
Difficulty with ambulation.
And what kind of pathologies did they have? Do you know or remember?
I think one of them was a large disc herniation, which was a little unusual, and then the other ones were usually OPLL with maybe a recent very mild trauma.
Yeah.
Like car accident or something.
Yeah, so again, back to that neurologic deficit, you can have a patient with underlying pressure on the spinal cord, and then even a relatively minor thing can bruise the cord, and now they have a central cord syndrome. An acute disc herniation that's not cauda equina could actually be pushing not on the cauda equina but on the spinal cord itself, and we would want to know about that pretty quickly. So neurologic deficit, again, is a clue that something might be an emergency. Yeah.
I was going to say night pain. So I had a patient with a really big tumor on his lumbar spine that was missed in imaging. And it was like 3 months prior to coming to me. And he just had really intense night pain where he just couldn't sleep. He was taking multiple showers every night, and that was the only thing that kind of soothed him.
Yeah.
But he still couldn't sleep.
Yeah, there's some tumors that are bone tumors especially that are worse at night, and they may not notice during the day. I'm not exactly sure the mechanism. Maybe there's certain prostaglandins or something that affect things more at night, but yeah. So kind of in that red flag category. Any other thoughts?
Patients had surgery and you're concerned.
Yeah, recent surgery, infection, or seroma, or hematoma are things. If a recent discectomy's happened, a recurrent disc herniation is another pretty common one. Good. Other thoughts?
Recent procedures too.
100%. We'll get into one on this. And for the record, nobody in this room caused that one, so no. But yes, recent procedure is an important historical thing. Chris?
Probably crossing the line into infectious disease here. Symptoms of meningitis, neck flexion,
Yeah.
or like the
Absolutely, 100%. Starting to get in. So you've got a patient in your office, and I think the thing to do is this an emergency, right? And you think about, okay, what do I know that's emergent? Trauma, infection, tumor, compression of some kind on the spinal cord or nerve roots from any of the above, like a disc herniation that's causing cauda equina. And how do I know that it might be emergent? Neurologic deficit, out of control pain, fever, and meningitis symptoms, and just sort of your pattern recognition for this patient doesn't look right versus I know this person and this is maybe their normal. And I think this is an issue that all of us face every day in clinical medicine. Is it something that needs to be escalated quickly, or is it something that we can work through our normal processes to address? Okay, any other comments? This patient was sent to the ER, and when you look at this, his white blood cell count was 12, ESR and CRP, which, if I'm honest, I don't even know the normal values, but I know if you see the range, then you can tell if it's high or not, right? So we'll just say they're both elevated. What do you think about that? You have this patient now in the ER. You've done some labs, which is commonly done in the emergency room. What do you do now? Alex?
For the ER, they're getting pictures taken.
Yeah, we got to do an MRI. Yeah, so this is a clue, the elevated temperature, and then just the fact that he's having weakness with a couple of risk factors, definitely want to get an MRI. So this is the MRI. You'll notice on the MRI he's had a prior surgery. Now this was a remote surgery. It was done, I don't remember exactly, maybe 5 to 8 years previously. Anything that people see on this MRI? I know that some are used to looking at images all the time, and all of us should be looking at them all the time. So what do you see? Yeah, the L2-3 disc here. We have it on T1 with contrast, T2, and CT, and it looks weird on all three. And then on the cross section at L2-3 with contrast, all of this is lighting up. And do you know what this is here on the side of the spine?
It's bad.
It's bad. Yeah, it's bad. Probably bad. The psoas muscle lives there, so there may be some infection in the psoas muscle, which is probably the reason why it's not so much neurologic injury from epidural abscess, but he's got infection in his psoas muscle, so he can't flex his hip. So if this works, I hope it does. So we took him to surgery, and we came in this way. How do you get it to play?
Go back to the video. Not troubleshooting. Enjoy. Okay.
Play. Just push on it.
My tea, it's on the way.
And so this is a lovely video to watch first thing in the morning. But we took him to surgery. I just thought, gosh, sometimes you would say, well, just have IR biopsy. And I thought, there's a lot of infection there. Let's do a small incision, because we're really only making a small incision and really understand what's going on. And once we got in there, it drained and drained and drained. Just acute pus. This is a 2-week process, and it was enough time to completely destroy the disc, fill the psoas muscles, and was close to probably injuring all of the cauda equina. And so anyway, the video just shows lots of pus coming out for a long time, just like this. Okay. And that's draining from the disc space, and maybe some of this is starting to get into, so we went in and cleaned it out, put him in a brace, and did not put hardware in initially. He proved to be unstable, so then went back in later and did the fusion when maybe your risk of infection later with the hardware is less. Okay, so I put this slide together looking at a few review articles, and if you remember anything about discitis and osteomyelitis, from my perspective, this is sort of the thing to remember. A couple of highlights. Not everybody has a fever. In fact, a lot of people don't. ESR and CRP give you incredible sensitivity. So if you're worried about infection, that is a really good test. MRI is also a very good test with contrast. You can look at risk factors. They all have some things in common with the exception of recent injection or recent surgery. And so that's something that you could have a relatively healthy person that had a recent procedure where that's all of a sudden something to think about. Whereas a lot of the patients that come in with an infection have some sort of underlying health issue, risk factor, like diabetes or malnutrition or smoking or poor dentition that clues you in. A big difference between infections in orthopedics, like in extremity, and infections in the spine is a lot of the extremity infections are direct inoculation through the skin into the joint. With the spine, they're traveling there through the bloodstream. So that's a little bit different. And then we'll do surgery in neurologic deficit, deformity, large abscess, and then importantly, these patients need to be on IV antibiotics for a long time, and watching their imaging and their ESR and CRP to track their ability to come off the antibiotics and the progress of the treatment. Okay. So this is a 37-year-old woman, neck pain for several months, no radiating symptoms, normal exam. Any concerns on this case at all? Anybody sending this patient to the emergency room? Here's her imaging. Do you see anything concerning on her MRI and CT scan? I see some head shaking. I didn't either. So she had maybe a little bit of reason for neck pain, a mildly degenerated disc. Okay. So she was treated with some physical therapy, and I can't remember, maybe one epidural injection, maybe two, and it seemed to maybe get a little bit better. And then shortly after this, she comes back, and she's had now severe neck pain for 2 weeks. She's unable to get out of bed. She has developed some weakness in her grips. Really nothing else. She's not febrile. She doesn't look like she's sick. What do you do now? This is a patient you just saw in the office 3 months ago, and you know what her imaging looks like. And the imaging that I showed you was 3 months prior to this moment in time. What do you do?
Her symptoms have changed, so you probably need to get an updated image on her.
I agree. Brandy, do you?
I would say the same thing with the new neurologic deficit.
You got to come and say something different. Like, no, I disagree. Like, this patient's fine. Lindsay doesn't know what she's talking about. Like, something like that, right? We need controversy. Yeah, and I think this is a challenge, right? You know this patient. You've seen her in clinic. She has. You're like, well, your MRIs look fine. Maybe you just strained your neck, and this weakness in your grip is your neck's hurting. So of course you're just not going to give us a full effort. So I don't know. It would take an astute person to pull the trigger and say, go into the emergency room, or you just had a scan. Insurance isn't going to approve another one. Let's get another scan, right? So anyway, somebody decided to send her to the emergency room. These scans are 3 months apart from each other.
Wow.
And she's already has a little bit of spinal cord signal change. The disc is destroyed. There's an arrow, which means something bad is happening. The facet joint is splayed, so it's starting to tip over, right? It's a very unstable situation. And then, what do you suppose these two arrows are pointing to? It's a T1 with contrast. So contrast would light. Could be a hematoma. Infection. So the infection, presumably this is as a result of an injection, but I'd have no idea. It could be from something else. So it's possible that the infection got into the disc, went all the way through it, and up and down the front of the spine, and that's a space that there's nothing preventing it from traveling up and down. Same with the, oh, you just let him play, that's good. So this is the psoas muscle, not psoas, the, what is it called? No, I can't think of it. The muscle in front of the cervical spine. And it's filled with infection. And this is not a normal exposure on a cervical normally you can just get right down there and longus coli and get the retractors underneath the muscle, and it's all just filled with infection. Nothing looked normal. The disc was destroyed. We went all the way down and layer by layer peeled this away, and at one point we got right through the dura and saw the little rootlet of a spinal nerve coming off the spinal cord, and thought, okay, we're not going to go any further. But we cleared it out and tried to correct the deformity.
Was the injection an anterior approach transfemoral? How did the infection end up anterior?
I don't know, but it was just a regular C6-7 posterior one. We don't know the cause of the infection. That's one risk factor that she did have, and it's a good question. I put my pins in this way and this way so that when I distracted it, it would open it up and actually put it back into good alignment. And I'm sorry, the video is kind of choppy, so we'll just move on. It's not that good of a video because nothing looked normal. So here's the correction. I put the screws in the back because I thought this would not be strong enough. And also, we may need to go back in and remove the hardware later because that hardware can get contaminated. And she needed hardware, but it can get a biofilm and be a persistent source of infection.
So this was an anterior and posterior approach?
Uh-huh. Yeah, I showed you the front part, and then after that was done, we went in through the back, wanting to get it to fuse for sure in the back, and then later we could take the hardware out when it's completely fused. So.
And when you do a posterior fusion like that, you're not touching the ligament or anything like that, right? You're just fixing the...
We didn't do any decompression from the back. We just put screws in. And she was pretty skinny. It was not a difficult thing to just go in and put their tiny little 14 millimeter lateral mass screws and lock it down. And then file down the facet joints and put bone graft down so that once that all heals in the back, then she's fused and we can take the hardware out from the front. Good question. When they've got that degree of deformity, just a front part is usually not enough to be stable. So sometimes we get away with it, but in this case I knew that we would probably need to remove the hardware, and so I want to see that it's fused in the back, keep her on oral antibiotics until the hardware's out as a prevention from the potential biofilm from seeding again and causing more infection. So, okay. I'll run through a couple of additional cases. The reason to show some different cases here is just sort of the pattern recognition, so that all of us can recognize when a patient probably needs to be seen. This guy had his wife left out of town at the worst possible time, and he was having some neck pain, and then she goes out of town and his neck pain got way worse. He wasn't even able to get out of bed, and then finally went in to the emergency room at the point when he really started being unable to move his legs, and then sort of the hands and triceps. On his imaging, he had an infection that had ruptured through the disc and severely compressed the spinal cord. We went to surgery. Brandy and I had 2 emergencies that night. One was a 10-year-old with an epidural hematoma, and then this guy, the 10-year-old did great, and then this guy never recovered. We cleared out this infection. I initially left the hardware out. I just cleaned it out really well, and you can see the spinal cord signal change on his postoperative MRI. And then he started to develop the kyphosis, and the disc would fuse on its own, typically in this case. So we went back in to just correct the alignment, make sure everything was okay, and restored it with and now that in a delayed manner, we were able to go in without the worry for putting hardware in the setting of infection. But he never really got spinal cord function back. his big risk factor was recent dental procedure, so a procedural context. He wasn't an unhealthy, maybe he had diabetes, but he was otherwise a reasonably healthy guy, and it was maybe a dental infection. This is a challenging one. A 36-year-old woman comes to see you, but she can't get out of the car. So you're in clinic, and I've wondered myself what I would do, and I don't want to answer it because I don't want to be honest, but you're in clinic. All of you have busy clinics. Some patient comes in, and then you're notified that she can't get out of the car, and so you're like, well, I'm not going down to the car. Go to the ER, right? Well, she didn't. She went to the ER 3 days later, and at this point, she hadn't been able to move her legs, no feeling, no bowel or bladder for about 3 days, and on history, she had had recent heroin use, mild fever, but ESR and CRP are elevated, and this is an epidural abscess in her thoracic spine with spinal cord signal change that's a little bit hard to see on this image, actually. There's the abscess. The spinal cord runs through, but you can see how much pressure's on it. And so that's a pretty difficult situation. I got this call in the middle of the night, and we'll get into that at the conference. But
Maybe you should have gone to the car when the sun was up.
yeah, no kidding. No kidding. I know. It would have prevented the middle of the night thing. 42-year-old woman, neck pain, normal exam. ESR and CRP were elevated. This neck pain was pretty severe, so she was in the ER. Pretty dramatic case where, again, that plane, there's nothing to prevent it in front of the spine, and there's nothing to prevent it from spreading in the epidural space inside of the spinal canal. So this infection went all the way down, thoracic and lumbar. We washed it out and put her on IV antibiotics. She never had any neurologic deficit, and it all cleared remarkably. Final one, 63-year-old, back pain. This is his second time in the ER in the past week. Normal exam. ESR and CRP are normal, and he's afebrile. And the question they asked me was, is this an infection? What do you think? Here's the images. You've got definitely some findings here of the disc at L5S1. A big gap with fluid in the facet joints. There may be a little bit of contrast enhancement around the facet joints. I literally had just studied for this when they called me, so I was prepared.
So I'm going to say yes, and the one thing I've learned this morning from looking at all these images is that the disc spaces and the defects, the edges look really ragged when it's infected. It's not a clean herniation. Like the edges, it's like a kid drew it.
Yeah, it's like, yep.
You said ESR and CRP were negative?
Yeah.
They're pretty sensitive.
Did you do blood culture?
They did not do blood cultures, and if they had, you would have to wait for a couple of days and admit him to the hospital and put him on preventive antibiotics. So he's in the ER. They're calling you. What do you think?
Cancer, leukemia?
No.
I mean, there's no red arrows, so there's no infection.
That's a really good point. I think you're onto something.
It's all good. It's all good.
Yes, there's no red arrows.
Tyler?
There's malalignment segmentally, so retrolisthesis, that could be related to some instability, which is causing an inflammatory response isolated to that level.
Yeah, that's a good point. Good point. Dr. Jackson, do you?
Try to look on the T1 if there's anything in the epidural space.
Yeah, there's something, maybe.
There's something in the epidural space. And those end plate changes make it a lot harder, though.
Yeah.
I mean, there's
If the lights went out so that you can look at this more carefully.
Better.
Oh, whoops.
I see what's going on in that epidural space a little bit more, but
Yeah.
the end plate changes. It definitely has some chronic component. I think with the end plate sclerosis.
Yeah.
But whether there's an acute on chronic is harder.
Yeah, it's tough. It's tough. Yeah.
Set arthropathy here, like whatever's going on in the sets is not normal.
It's not normal.
I mean, mean, it could be just from lots of motion like we're talking about.
Yeah. So this is a funny call because study regularly, because when you study, you start seeing stuff. I had just prepared this talk. This was about 2 months ago. And I had just read all the articles on osteomyelitis and stuff. And so I knew the answers. And I'm looking at this, I'm like, it's not an infection. His ESR and CRP are normal. This is a chronic disc problem with the end plate sclerosis and retrolisthesis, and there's remodeling. We see that all the time. And what's going to happen at 4-5 when you have a thinned out disc? He's going to rock back on his facet joints, and you're going to have a worn out facet joint. And then he's exacerbated this. And so I said, this is a normal degenerative condition, and ESR and CRP are so sensitive to this. No fevers. Now, instruct him, if things worsen. But I think you're right to look at this epidural thing, and it's a little bit calcified there on the CT. But this was a case where I was fairly confident that this was a exacerbation of a degenerative issue, not an infection. So in conclusion, there's kind of your cliff notes for osteomyelitis, discitis, and hopefully a recognition that these are emergencies. Most of the cases we deal with are not, and hopefully we can all make good clinical decisions on when to escalate versus reassure and tell the patient that this is a normal thing or something that we can work with you on in an outpatient setting. Thank you very much.